তো তুমি শুনতে পাচ্ছ?
Yes,
Yes,
sir.
sir.
আচ্ছা ঠিক আছে,
Yes, sir.
আচ্ছা ঠিক আছে, ওকে ঠিক আছে। কিছু দেখতে পাচ্ছ? স্ক্রিন শেয়ার হচ্ছে তাই না?
Sir.
এখন কিছু দেখতে পাচ্ছ?
স্যার মনিটরটা দেখা যাচ্ছে।
মনিটরে কি দেখা যাচ্ছে? কোন ছবি?
জি স্যার।
হ্যাঁ, এটাই দেখো। আমি এখানে সেদিন তোমাদেরকে বলেছিলাম যে পাঁচটা বিলো দ্য umbilicus, below the umbilicus the peritoneum makes 5 folds: median umbilical fold, medial umbilical fold pair, and lateral umbilical fold, right? 3. And thereby 6 foci are formed. 2 supravesical, these two, as it is above the, this is key, vesicle, that means urinary bladder. So as it is above the urinary bladder, these two are called supravesical fossa. And just lateral to that, medial inguinal fossa is this one, which is bounded laterally by inferior epigastric artery and medially by the lateral border of the rectus sheath and below by the umbilical inguinal ligament. So this is the medial inguinal fossa, and lateral to this is the very important anatomical landmark, surgical landmark for the surgeons to determine and to make the surgeries decide over this inferior epigastric artery. You must remember this one, the inferior epigastric artery. You can see it. So this, if something comes out lateral to this, it is called indirect inguinal hernia. Or we can say, if something comes out through the lateral inguinal fossa, this is the lateral inguinal fossa, this is the medial inguinal fossa, and this is the supravesical fossa, right? So same on the left side, supravesical fossa, medial inguinal fossa, lateral inguinal fossa. And you know what is hernia? Hernia is protrusion of any viscous. Hernia is what? Hernia is
Protrusion
what?
of any viscous.
Unusual protrusion of any viscera.
Through any opening or any point, it is called hernia, right? So if the abdominal content, only normally it is the testicles, and in case of female, it along with the round ligament of the uterus that can come to the outside of the abdominal cavity normally. But if something else comes out, that would be called hernia. So that is the landmark. If something comes out through this lateral inguinal fossa, then it is called what? Indirect inguinal hernia. And if something comes out medial to this inferior epigastric artery, that is called direct inguinal hernia. And again, there are two varieties: lateral,
medial and lateral.
right? So medial and lateral. This is demarcated by the obliterated umbilical artery. You will not understand everything of this obliterated umbilical artery, umbilical veins. So I'm not going to detail. Just remember, this is an obliterated umbilical artery, and that makes the boundary of this. Anyways, this is in short, you will study what is the difference between indirect inguinal and direct inguinal hernia, what are the linings, and what makes the linings. I have told you in the last class. If you just remember the picture I have shown you, how the internal spermatic fascia, how the cremasteric fascia and external spermatic fascia is formed, you can understand everything. Who can tell me how the internal spermatic fascia is formed, or what continues as the internal spermatic fascia from the deep inguinal ring? Who can tell me?
Fascia transversalis.
Very good. And how the cremasteric fascia is formed?
From the detached fibers of the internal oblique muscles.
Lower arcuate internal fibers makes a sheath-like structure on which they remain an U-shaped loop. This is called a cremasteric fascia. And how the external spermatic fascia is formed?
Spermatic fascia forms by the from the external oblique muscle.
Right. Aponeurosis of the external oblique continues from the superficial inguinal ring along the spermatic cord and makes the external spermatic fascia towards the testicles. Right? That is, I mean, the scrotum.
Beneath the dartos muscle.
Very good. Replacing the dartos muscle. It is replaced by the, so very good. So you have the idea. So you can understand what structures will be the covering of these particular type of indirect or direct inguinal hernia, right? Okay, I'm not going to detail it anymore. I just want to show one thing to you. I always tell you, please go through the videos. Why I tell you, you see, this is a video from the Aucklands and very nicely shown this gap. I want to show many things, but it's not possible to show all the things. Just see, there is a huge gap in the anterolateral wall of the abdomen, which is marked above by the costal margins, below by the iliac crest, pecten pubis, and the symphysis pubis. But what about this gap? What about this gap? And how this gap is filled up? You know, there is a huge, plenty of transverse muscles. I mean, that is flat muscles. These are external oblique, internal oblique, a transversus abdominis, and a straight rectus abdominis. These, along with the sheaths and aponeurosis, they cover up the gap between it to make the floor of it and the structures which forms the femoral sheath, which forms the femoral canal, I've told you in details. But you go through this video and you'll understand in everything that I want to mention. And you'll also see that if you go through this video that I've told you that this inguinal ligament is a downward slope which turns upwards. So it has a convex surface. Why? Because it is pulled up by the fascial lata that I've told you. And this is very nicely shown in this video. And many information you can understand from this video that you will never ever be able. Say, for example, arrangement of the rectus sheath, rectus abdominis muscle, arrangement of the transversus, then the how the rectus sheath is actually formed and how it looks like, because you don't have the facilities right at this moment to go to the cadavers and do these dissections by yourself. So please go through this video so that at least you can see the how the anterorectus sheath is looks like, how will be, if I cut, how it will look like, what will be the contents inside, and what is the tendinous intersections. They have showing that in this part they are showing that these tendinous intersections are firmly holding the anterior rectus sheath, but the posterior layers, as I've told you in my class, is very free. And you see, this will help to visualize. These are the tendinous intersection, and that is the posterior layer of the rectus sheath. So everything is there. You just go through this video, and this is the muscles on the lateral wall. the transversus abdominis. From below they are coming. Then the internal oblique. Then comes the external oblique. And when the external oblique comes, then you will see the inguinal ligament and inguinal region in this video elaborated. This is the external oblique. So I'm just skipping so that you can see how these epineurises are forming the rectus shift, and which is linea alba, and everything is here. And more details, you will be able to understand the inguinal region. Very important for the surgeons. You see, this inguinal region, I told you, is the rigid box. That means the box, the abdomen, anti-abdominal wall is your bread and butter earning material. All the general surgeries are done, most of the general surgeries are done through the intra-abdominal wall. So this is a bit detailed of the inguinal ligament, and here they are showing that how the inguinal ligament is continuous with the fascial ladder, and what are the modifications. You know the lacunar ligament, then the pectineal ligament, and the reflected part of the inguinal ligament. All these are the medial modifications, and everything is shown here. So please, I request you, along with the books, you go through this video, and you'll hopefully, as I've told you, this is the lacunar ligament, and you all know this. That's why I'm skipping and just skipping so that you can see the attachment of the muscles, and this shows you how the external oblique actually is forming the inguinal ligament. Is some fibers detached and upturned on himself is forming the ligament, and in details. So I'm concluding this part. Just I'm raising the point that you should go through these pictures and videos, and thereby you match your understanding of the bookish knowledge with these practical ones. Semi-practical, should I rather say. If you could touch the cadaver, that would have been the most important. And now you see how the superficial viewing looks like in the real life. Okay, but still, it's not the real picture because it is covered with the external spermatic fascia and makes a tunnel-like structure. So this is an artifact, as I have told you. This is an artifact. It is not seen in the real life, whether it is continued along with the external spermatic fascia. Okay, so I'd like to conclude this part. Now, I just raised the push point, and this is my duty as a teacher, as a facilitator, to raise the points so that you yourself can go through the books and match it. Okay. I'm making a bit hurry because I have to start the lever. Okay. Do you have anything else to ask about? Anything else to ask about the anti-abdominal wall? I think it is discussed in details. Just you go through the book now. Liver is an organ which is located here. And from this figure, you can see most of the part of the liver is hidden beneath what we call thoracic cage, right? Isn't it so? Though it's an abdominal organ, but it is beneath the thoracic cage mostly. So we have a protection, but at the same time, we have some misleading concepts about the ideas about the location. We think liver is far below. No, it's inside the thoracic cage mostly. So we can show the position of the liver in other figures like this. Here you can see there are some other books, very nice books. Okay. You see, this is a very nice book, clinically oriented pictures are very nice. This is the position of the liver, and it is also showing the position of the liver in neutral respiratory state, in inspiration, in full expiration. You can see in full expiration, it almost reaches the nipples, right? Nipple is an important anatomical landmark, but normally it is at the Giffey-Sternal joint level, but a bit higher on the right, but almost at the Giffey-Sternal level. But that is what we call. And And these 4 to 8 centimeters in the midline, 6 to 12 centimeters in the right, these are very important to understand because whenever you do have to do as procedure in the liver, we have to remember these facts, or else we'll be injuring the underlying structures like the kidney, like the colon, or if we go above, we would be injuring the lung pleural cavity. So many important, infravena cover itself is there. So many important structures are related with the liver. And if we just go like carelessly and without any attention, if we go for procedures in the liver, we frequently have to do that and it will be damaging. So you must know how the liver is located and where. And if you see this view, you can see the relation of 3 vital organs, the lung, the liver, the right kidney. So you see, they are very close to each other. The just lung and the liver are separated by a thick muscular septum, that is the diaphragm, and below the liver is the right kidney. So these structures are so close to each other, and there is a space that is called hepatorenal space, renal recess, and there are other subphrenic space. That means liver is surrounded by some spaces. This is called subphrenic. Why it is called subphrenic? The reason is very obvious, because it is below the diaphragm. Why it is called hepatorenal? Because it is between the liver and kidney, and it will usually lodges all the fluids which are lodged here, because it's the most dependent part when we lie down. Now he is standing, the person is standing, that's why it's not vertical one. But when we lie down, then this becomes the most dependent part, and all the fluids are collected here, pus and everything, pus, material, blood, everything is collected here. So any surgery, we put any drain here to drain the collection. So just have an idea how the liver looks like, and let us, yes please. Sure. Okay. See, liver is a wedge-like structure. Wedge means kilok, or we can say it's a pyramid-like structure whose base is located to rests on the left side, right side, and the apex goes upwards. And it is mostly in what regions of the abdomen? You know it. In which regions of the abdomen the liver is located? In the
left hypochondriac. So right hypochondriac, epigastric, and right lumbar.
Partly in the left hypochondriac region. Right. Very good. So this is the location of the liver, and if we see again, there is another relationship with the stomach. There is another relationship with the stomach, and the entry of the liver is called the porta hepatis. You know all these things. Porta hepatis. Porta hepatis is the what? Porta hepatis is what?
Opening.
Actually, it's not opening, right? It is the pathway through some structures enter or exit from the liver. This is called porta hepatis, right? This is called porta hepatis. What is called porta hepatis? Porta means port. In simple usage, we use the word port for what? We use the simple word port for entry, right? And porta hepatis means entry of the liver. And as you know, entry of the liver would be for entry of some arteries and veins, and exit of some vein. But you remember, the hepatic vein doesn't exit through the porta hepatis. That usually happens in other organs, right? In other organs, the artery and veins passes through the same opening, like in the lungs you have studied. Have you studied the lung? Yes, you know. You know in there, the hilum of the lung allows the entry and exit of the structures. In the kidney, you'll study the hilum of the kidney allows the entry and exit of the renal artery and renal vein. But remember, hepatic vein never exists through the porta hepatis. it usually have no extrahepatic course even. The what I have told, the what I have told that the portal, the hepatic vein doesn't have any extrahepatic course. It just comes out from the liver and immediately enters into the inferior vena cava, right, on the posterior surface of the liver. I'll show you, just have an idea and remember it, that the hepatic vein doesn't exit through the porta hepatis. It has got very small, very little extrahepatic course. It immediately coming out from the liver, it enters into the inferior vena cava and helps in the holding up of the liver in this huge 1.5 kilogram this liver weighs, and it almost weighs 2.5% of our total body weight, and it takes per minute 1500 milliliter. That means almost 25% of the cardiac output is going to the liver. So you can understand only 2.5% of the weight of the body, but taking up almost 25% of the blood. So how much vital it is and how much important it is to maintain the blood supply of the liver. That's why liver has got two sources. I will be coming to that. Liver has got two sources of blood supply. One is portal vein and one other is hepatic artery. We'll come to that. But just see where we had been, that liver porta hepatis is the entry for some structures and exit of the structures. So actually, how does it look like? It looks like a wedge. And how many surfaces are there? How many surfaces are there in the liver? Who can tell? How many surfaces are there in the liver? Any idea? There are actually two surfaces. One is the diaphragmatic surface, or called parietal surface, and one is visceral surface. These are the two surfaces of the liver, right? One is what I told you, parietal surface, and one is visceral surface. Parietal surface, or I mean the hepatic this is the superior, the surfaces of the liver, and diaphragmatic surface, as you can see, diaphragmatic surface is divided into superior, anterior, right lateral, and posterior surface. And the inferior surface or visceral surface is another one. And these three, particularly the posterior surface, is separated from the inferior surface by a sharp border. That is called inferior border of the liver. We'll see it. This is the sharp border, sharp inferior border of the liver, which is separating the inferior surface from the posterior surface. Posterior surface is again the part of the diaphragmatic surface. That means this is the superior border surface, this is the right lateral surface, and this one that we can see is the anterior surface, and posteriorly is the posterior surface. And we'll see one by one these things. So this is again the anterior surface, this is the superior surface, this is the lateral, right lateral surface, and just where the inferior vena cava is the posterior surface, and here actually just behind this inferior border is the inferior surface. And this inferior surface goes upwards and backwards to meet this posterior surface. Now you can see the posterior surface. This is the posterior surface, this is the superior surface, this is the right lateral surface, and this is actually the inferior surface. And altogether we say this is posterior inferior surface. Altogether we tell it posterior inferior surface. Though posterior surface is the part of the diaphragmatic surface, and inferior surface is a different surface, but they meet each other. But the right lateral surface, superior surface, posterior surface, and anterior surface are not demarcated that much sharply, right? There is no sharp margin which will demarcate the superior from the lateral, right lateral, superior from the anterior, superior from the posterior. But only one is this inferior surface, which separates the inferior surface from the anterior surface, like this. You can see. Next, there are some peritoneal attachments that is very important. We usually see in Visram's things. This is the ligamentum teres hepatis in the falciform ligament, and this falciform ligament goes to the left, goes to the right, and how it is, we'll show it in details. How it is actually arranged. You see this one in the Argelast's anatomy, very nicely written. Let us start it from here. This is the falciform ligament. Why it is called falciform ligament? It is like a sickle. Sickle mane ki bolo to? Sickle mane ki? Kaste. It's like a sickle which holds the anterior abdominal wall, attaches the anterior abdominal wall with the liver above the diaphragm. Above the umbilicus. Above the umbilicus, this falciform ligament holds the anterior surface of the liver to the anterior abdominal wall and above to the diaphragm. So this is called falciform ligament, and it lodges the ligamentum teres hepatis. What it is, I'll be telling you later, but have an idea. This falciform ligament goes all the way in the anterior surface and then turns to the right and turns to the left. When it turns to the right, it takes a different name. Upper layer, this is called now coronary ligament. Coronary ligament, and coronary ligament has got two layers. This is the upper layer of the coronary ligament, and this is the inferior or lower layer of the superior layer and inferior layer of the coronary ligament. And they actually cover up a triangular area. This is called the bare area of the liver. The bare area means there are more bare areas in the liver, right? This is the bare area, which is bounded medially by the inferior vena cava and above by the upper border of the coronary ligament, below by the lower layer of the coronary ligament layer, and these two layers meet at the right triangular ligament. Next, what happens? This inferior layer of the coronary ligament passes in front of the inferior vena cava to reach the apex of it, that means the liver, and then meets the diverging layer of the right layer of the falciform ligament and goes and covers up to meet a deep sulcus. Deep sulcus for what? Ligamentum teres and ligamentum venosum. This is for the ligamentum venosum, and then it makes a right angle turn to form the porta hepatis. So all these are continuous. You can see these are all continuous, but this is not seen in other figures, but it is very much continuous with these, and it turns up to make the right border of the group for the ligamentum venosum, and this is for the ligamentum teres, group for the ligamentum teres, and this is the porta hepatis, right? And then again, these, now about this one, the left one. The left one goes as similarly as the left triangular goes and meets to the left side and turns back as the left triangular ligament and covers the esophagus and all the structures to form the anterior layer. But the posterior layer is formed by the greater omentum. You will not understand what is greater omentum right at this moment, but just have an idea. So this greater omentum forms the posterior layer, goes beyond the esophagus, then completes the cycle. This is the completion. Again, this layer is the continuation of the lesser omentum. This layer is the lesser omentum, and this continues, goes backwards, and I'll show you the relationship of the lesser omentum with the porta hepatis. Other figures. So have an idea that liver is almost everywhere covered by the peritoneum, except these the bare area, and the group for the inferior vena cava, group for the fossa for the gallbladder, and group for the fissure for the ligamentum venosum, and fissure for the ligamentum teres. Other than this, and porta hepatis. Here there is no peritoneal covering. Other than that, everywhere the liver is suspended, covered by peritoneum. Now, after the peritoneum, there is a thin but very tough Gleason's capsule, a connective tissue layer which covers the substance of the liver. Right. So this is in short and very detailed, in short but very effective one. I've taken it from the which book you know. This is the R.J. Lust's Anatomy. Very nice book and very effective because this R.J. Last was a surgeon. Actually, he is an FRCS surgeon. Not only that, he is an examiner of the FRCS. He has deceased. So he was a very senior member of the FRCS examination board. But when he was examining the students, he found that the students, not only in our country, but also in United Kingdom, the students lacks anatomical knowledge, which are very important for surgeons. That's why he wrote the book that is this one, the R.J. Lust Anatomy Regions by Regions. Very effective one. Okay, so this is the R.J. Lust Anatomy, and where he has shown many figures, very concise book, but if you study it after you've studied other books, it will be very helpful and it will give you the information that you needed during the surgery. How will you operate in the liver? How will you remove this layer? Why should you have to remove this layer to enter into the porta hepatis? If you don't understand that the lesser omentum is attached to the left margin of the ligament venosus, which is continuous to the porta hepatis, you'll not understand why the surgeons, when doing any surgery on the gallbladder, have to cut it and make a hole to get into this porta hepatis to get a control over this cystic duct. So if you want to have a bile duct operation or you want to have a operation on the gallbladder, you have to actually follow this course. Now, again, let us come back to the point. This is another, now, how the liver is divided. Anatomically, we divide the liver by the attachment of these ligamentum teres, the falciform ligament in the ligamentum teres in the falciform ligament into two mismatch. The right one is bigger, much bigger than the left one, and this is called the anatomical right lobe, and this is called the anatomical left lobe. But in practicality, the right lobe and left lobe is not that one we are anatomists doing or making the divisions, because they don't follow any sort of circulation pattern or bile, because oh sorry, one thing I have missed. You know it, liver is the largest gland and the mixed gland because it has got both exocrine and endocrine secretion. Exocrine secretion is the bile, you know it, and the endocrine secretion are some hormones, right? So these gland definitely has to have some blood supply pattern and some exocrine secretion pattern. That is maintained by, if we join the center of the gallbladder, fossa for the gallbladder, and center for the inferior vena cava in an oblique line, that almost makes an 50-50 demarcation. This right half belongs to the right lobe, and the left half belongs to the left lobe, right? And that follows the blood circulation pattern and the excretion of the bile pattern. So this is much more pertinent to know. And from ultrasonographic point of view, from radiological point of view, this is more important than this one. Why? Because I've already told you, the hepatic vein doesn't exit through the porta hepatis. I've told you. Hepatic artery enters, portal vein enters, a common bile duct exits, nerves enter, but not the hepatic vein. Hepatic vein originates from the liver substance itself. There are three hepatic veins: right hepatic vein, middle hepatic vein, and left hepatic vein. And these line, when we join the center of the gallbladder with the center of the inferior vena cava fossa, is actually in line with the middle hepatic vein, right? So in means inferior vena cava, three hepatic veins immediately after they come out from the liver, they enter into the inferior vena cava. That's why we told you the hepatic veins don't have any extra hepatic course. They straightway enter into the inferior vena cava. Right one on the right side, left one on the left side, and the middle one straightway in the center of the inferior vena cava. And that center line is the most important thing for radiological purpose, for I mean other purposes, surgical purpose everywhere, and particularly for the to understand the circulation, we must maintain this line as the demarcation line. Now, two more things, two more lobes. This is caudate lobe and this is quadrate lobe. Caudate lobe and this is quadrate. Everywhere you get the term caudate means a tail-like structure. This is the caudate process. And as this lobe has got this caudate process, it is called caudate lobe. Caudate means it's a tail-like process which lies between the inferior vena cava and the fossa of the gallbladder. I mean the porta hepatis. There is a continuation of this lobe. This is why this is called the caudate lobe. And the caudate lobe is bounded on the right by the inferior vena cava and below by the porta hepatis, on the left by the fissure for the ligamentum venosum, and on above by that I've told you the two layers of the falciform ligament and the diverging layer of the falciform ligament and the inferior layer of what? Inferior layer of the coronary ligament. This is the caudate lobe. And quadrate lobe is bounded above by the porta hepatis, on the right by the fossa for the gallbladder, and below by the inferior border, and on the left by the fissure for the ligamentum teres. So this is the quadrate lobe and this is the caudate lobe, right? Okay, fine. And there are some impressions of these in the on the liver, on the inferior visceral surface, and altogether these inferior surfaces and posterior surface are called what? They are called the visceral surface, and there is there would be esophagus, then the stomach, then the pylorus of the stomach, then the small intestine is going back, then there is the colic flexure, right colic flexure, and the right kidney, for impression for the right kidney is there. So these are the impressions, visceral impressions on the liver. I'm just telling you about the arrangement of the viscerals, and I'll show you them. I'll show these figures here. In your book, this is very nicely shown. But one thing you must remember, liver is such an organ that is placed very much strategically, not only strategically, very much strategically. How strategically it is located, you'll see, and you'll be wondering how strategically it is located. Very much strategically it is located. And the strategy is so nice. If we go to the, it is very close to the heart. Again, it is taking up all the blood from the gut. You see, this is the strategy that makes the liver's position very much unique. You see, this is the liver, and beneath is the stomach. Then these are all the coils of intestine, small intestine, large intestine. So everything is very close to the liver. And not only that, just above it is the heart. So it is very much strategically placed. And how strategically you will see further when you see that the location of the liver is supported by blood vessels. You see, now you can understand. All the blood is from the organs are very easy to reach the liver. Not only these hepatic artery, but in case of this, the portal vein, you know, now you know, by this time you might have known, portal vein is formed by the union of the splenic vein and supramesenteric vein. And supramesenteric vein, no, you know it. And then it enters into the liver very short distance, very strategically placed, so that all the nutrition-rich blood can reach the liver through the portal vein, and all the oxygen-rich blood can reach the liver through the hepatic artery. So strategically it is placed, and then then these two kinds of blood, the oxygen-rich blood and nutrition-rich blood, but less in oxygen, is mixed up in the liver in such a way that maximum utilization of these metabolites and oxygen is possible. It is part of the histology, and Professor Shigupta Madam will nicely elaborate it, I know, and she is very expert in that. So you'll be understanding that thing in histology classes, but I'm not going to that. But after that, the hepatic veins are formed. And these hepatic veins, as I've told you, enter straightway into the inferior vena cava. Then this inferior vena cava blood goes to the right atrium of the heart after crossing a very short distance. So everything is so economically and so strategically placed. If the liver were here in below or elsewhere, then we have to have these complicated structures going down, then again coming up all the way back. So you can see the position of the liver is so much strategically placed that it can take up all the oxygenated blood it needs and all the nutrition-rich blood at the easiest possible way. Okay, let us go to the next point, that what I want to mention, that so far we have discussed about how the liver is located, where the liver is located, what is the position of the liver, and what is the lobes, what are the lobes of the liver, two lobes of the liver, and what are the external features of the liver. We have, but one thing we must remember, there is a segmentation of the liver. Do you know this term, segmentation of the liver?
No, sir.
Segmentation of the liver, you see here. This is called the segmentation of the liver. What does it mean? Segmentation of the liver. As I have told you, you see this line, as I have already told you, is the center for the fossa for the gallbladder and center for the inferior vena cava. Is joined by an imaginary line, and that makes the true or physiological lobes of the liver, that is right and left. Then right again is divided into anterior and posterior, and left is divided into lateral and medial one. So again, these anterior and posterior and lateral medial are sub-segmented. So these four. So actually we have got four segments of the liver. Right anterior, right posterior, left lateral, left medial, right? And how they are actually, and you see from this figure, the middle hepatic vein is making the model, the demarcation point. The middle hepatic vein. The right hepatic vein, this is the left hepatic vein, and this is the middle hepatic vein. Your Visram Singh is a very nice book, but you have to understand these things with the help of other books, and you will understand these figures when you go through the details, and then you will be able to correlate in your practical life. So you can see these, as I've told you, this is the medial hepatic vein which is making the demarcation line. And when the hepatic artery enters through the porta hepatis, within the porta hepatis, which make the right and left hepatic arteries branches, then when it enters into the substance of the liver, it makes an segmental branch, right anterior segmental, right posterior segmental. Similarly, the left hepatic artery branch actually branches and makes two branch for the left medial and left lateral segment, then subsegment, and as I've told you, the liver is covered by peritoneum, and below the peritoneum it is covered by a thin but very well tightly adherent capsule that is called Gleason's capsule, and at the porta hepatis, this Gleason's capsule sends septum inside the liver and this septum divides and makes a classic hepatic lobule, a hexagonal structure covered by connective tissue that will be discussed in the histology class. But have an idea, this connective tissue is going inside all the areas of the liver and making small lobules. These are called classic hepatic lobules, which are related to the structure of the liver. But one thing you must understand, these portal vein. This is the hepatic artery. But when the portal vein again enters, that also follows the same pattern. The portal vein enters and portals branch for the anterior segment, portal right anterior segment, portal vein branch for the left anterior, right posterior segment. Similarly, left medial segment for the left lateral segment. They form the branches, right? And they again give smaller branches to reach that I have told you hexagonal area of the liver, smallest hexagonal area that will be discussed in details in histology. Hexagonal areas of the liver. Just I'm to show you one time, so that you can have an idea. This is what I'm telling you. Oh, sorry, it is not here. Anyways, the hexagonal structure of the liver is there. Hexagonally arranged area in the liver, small areas. These are called classic hepatic lobules. And these hepatic lobules are surrounded by connective tissue sheaths. So the porta hepatis allows the entry of the hepatic artery. Porta hepatis allows the entry of the portal vein, which branches along these septum, connective tissue septums, to reach that very much microscopic structures. Understand? That is what I want to mention very seriously, that these macroscopic structures, these are all, the hepatic artery is a macroscopic structure. The hepatic portal vein is a macroscopic structure. These hepatic veins are also macroscopic structures, but they branch till they reach the microscopic hexagonally arranged areas. So, understand. And they mix up in the sinusoids, liver sinusoids, that will be discussed in the histology classes. So we have discussed about now how the liver is held up. This huge thing, 1.4, 1.5 kg structure is held up in the abdominal cavity. It might raise curiosity in your mind, isn't it so? How is this liver held up? The first thing is the anchoring by the hepatic veins and inferior vena cava. Because you see, inferior vena cava goes behind the liver, right? Just behind the posterior surface of the liver, inferior vena cava goes. So inferior vena cava is attached above to the right atrium through the diaphragm, and below it is originating with and getting the tributaries from other structures. So it is a very strong structure now which can hold up, and the liver is held up by those three hepatic veins, and these all together is holding up the liver. This is very important anatomical structures. But there are some non-anatomical structures like intra-abdominal pressure. This intra-abdominal pressure also helps to hold up the liver. Yet there are some ligaments which also helps to keep the liver in position. Like what ligaments? How many ligaments are there? I've already told some ligaments like falciform ligaments, coronary ligament, right coronary, right triangular, left triangular, and lesser omentum that I have not yet mentioned. But these are called false ligaments. Why? Why they are called false ligaments? Because actually they are not ligaments. They are folds of the peritoneum. They are truly to say these are the folds of the peritoneum. That's why they are called false ligaments, right? And see, this one is the falciform ligament. I'm showing you. Falciform ligament is located where? Falciform ligament. This one here is the location of the falciform ligament. Falciform. Have you seen it? Falciform ligament? Falciform ligament is located, which holds from the, if it is the umbilicus and this is the diaphragm, then there is a membranous structure here, like here, which will hold the liver anterior surface and attach it to the anterior abdominal wall, and to the diaphragm above. Then it would be called falciparum ligament. Okay, I'll be showing you the falciparum ligament later, but this is the falciparum ligament. And now you can see where we had been. The coronary ligament, you know, the right triangular ligament, you know, the left triangular you have already seen, and the lesser omentum. This one is very important to understand, that lesser omentum. From here you can see the stomach. This is the stomach, and it has got one end. This end is called the medial end towards the liver, and this is attaching to the porta hepatis through the lesser omentum. And this one is not written here. This is the greater omentum. You'll study it. If you have studied, you know it. Have you studied the GI tract?
Stomach.
Stomach you've studied, so you know it. Lesser omentum, lesser curvature, greater curvature, know it, right? So then you can understand this is the lesser omentum. From this figure, you can see the lesser omentum is going to the porta hepatis, and I have shown you in the picture of the RJ last that the left margin of the fissure for the ligamentum venosum is attached with the lesser omentum, and the right one is attached to the inferior layer of the coronary ligament. I've shown you in the first thing that I've shown in the RJ last picture. So you now understand the porta hepatis has got a continuation of the lesser omentum. Next thing, I wanted to show you that this is the peritoneal, the visceral impressions. One is this is the esophagus, then this is the posterior inferior surface. This is the inferior surface, and this is the posterior surface of the liver. And you can see this is the location of the esophagus, then the stomach, then this is the pyloric region, then is the lesser curvature, the duodenum, then this is the right colic flexure, and this is the location of the kidney, right kidney. And this is the right suprarenal gland. And you'll not understand right at this moment, but I want to just mention that tuber omentalis, there is a term tuber omentalis in the lesser omentum, just at the porta hepatis. Tuber omentalis hepatis is a protrusion here, and there is another counterpart in the pancreas that is also called tuber omentalis, and there is bulging. These two bulgings are very close to each other, and actually this is a guideline for surgical purpose. We will be telling it about later, but here is just an idea. When we will be discussing about the pancreas and also the peritoneum, only then you will get the complete picture. What is tuber omentalis, and where it is located, and how should we approach these gallbladder, because this is very common surgery for the general surgeons. And you must know epiploic foramen. That is another thing you must know, epiploic foramen. Just note down these things, that all the students, boy students and girl students, this is another picture. That this one is does just same thing. This is the stomach, and this is the porta hepatis, this is lesser omentum. And now you see actually how they are related. This is the lesser curvature of the stomach, and this is the greater curvature of the stomach. And at the greater curvature, you know the greater omentum is attached, and the lesser curvature, the lesser omentum is attached. And this lesser omentum goes, as I've told you, converges towards the porta hepatis, where there is VAD, vein, artery, duct. Similar, portal vein, hepatic artery, bile duct, VAD, V-A-D, like vein. You have studied the vein in the intercostal space, vein, artery, nerve. You study the VAP, vein, artery, pelvis in the kidney, hilum of the kidney, same VAP, vein, artery, pelvis, before backwards. Similarly here, the portal vein, then artery, then duct, VAD, V-A-D. This is the entry of the structures, and bile duct of course comes out, the structures which enter and exit. But you now from this figure you can understand the relationship of the lesser omentum with the porta hepatis. And if I go further, If I go further, you'll see actually you'll not understand. I know you'll never understand this picture right at this moment, but have an inquisitive mind, have a query in mind how the stomach and the lesser omentum is entering into the porta hepatis, making the porta hepatis. Okay, you'll find it difficult to understand, but this will be very easy to understand when we will be discussing the arrangement of the peritoneum. It's not that tough. Peritoneum is not that tough. Just have a patience, and the next class, if I get the chance, we will be completing the abdomen, the liver. Already we have discussed about the liver. We'll be discussing of the extra hepatic parts of the biliary apparatus and then the pancreas. Okay. So any question, please? Any question? Any question, please? Sana, Iqbal, or Kaif? কোনো question আছে?
No, sir.
বুঝতে পেরেছো সানা?
Yes, sir.
না সত্যি করে বলো বুঝতে পেরেছো কিনা? কারণ আমি কিন্তু একটু জটিল করে পড়িয়েছি। লিভার যেরকম সহজ করে সব সময় পড়ানো হয়, এইবার আমি ইচ্ছে করে একটু অন্যভাবে পড়িয়েছি। কেন? কারণ সবসময় লিভারটাকে পড়ানো হয় খুব সহজভাবে। পড়ানো হলে কি হয়? এই যে একই পেরিটোনিয়াম যে ঘুরে 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 সব জায়গাতে কভার করে আছে, এই কনসেপ্টটা আমাদের তৈরি হয় না। আমরা হালকা চলে পড়ে যাই যে এইটাই, কিন্তু এইটাই যে ঘুরে আবার ইনফ্লুয়েভেন একেবারে সামনে দিয়ে এসে এইটাই যে আবার কন্টিনিউশন হয়ে এসে পোর্টা হেপাটাইটিসে চলে আসলো, বর্ডার তৈরি করলো, একই জিনিস ওর বইতে আলাদা 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 করে লেখে, কিন্তু অ্যাকচুয়ালি এইভাবে কিন্তু হয় না। তুমি সার্জন হতে হলে তোমাকে জানতে হবে যে এটা একটাই জিনিস ঘুরে 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 আছে, কোথায় কোথায় নাই, কোন ভাবে আমি অ্যাপ্রোচ করব। আমি আশা করব তোমরা এইটা পড়ার পরে যদি আরজে লাস্ট থাকে তোমাদের কাছে, থাকলেও না থাকলে আমি পাঠিয়ে দিতে পারবো তোমাদেরকে ভেরি ইজি 3 পৃষ্ঠা, মাত্র 3 পৃষ্ঠা। আরজে লাস্টে হার্ট হচ্ছে মাত্র 4 পৃষ্ঠা।
স্যার হোয়াটসঅ্যাপে দিলে স্যার ভালো হতো।
হোয়াটসঅ্যাপে দিয়ে দিব?
জি স্যার।
তাহলে দিয়ে দিলে তো খুবই ভালো, আমার পক্ষে দেওয়া খুবই সহজ। হোয়াটসঅ্যাপে কিসে দিব বাবা বলো তো দেখি?
স্যার ওই যে হিস্টোলজি গ্রুপ আছে স্যার, আমাদের ক্ষেত্রে আমাদের ওটাতে দিয়ে দিলেই হবে স্যার। আমরা 40 জন ওখানে অ্যাটাচ দিই, সেখানে দিয়ে দিলে আমরা সেটা পরে আবার সব জায়গায় দিয়ে দিই।
পরে হচ্ছে আমরা সেটাকে সার্কুলেট করে দিতে পারবো।
আচ্ছা আচ্ছা আচ্ছা, ঠিক আছে, একটু ভালো বুদ্ধি দিয়েছো। ওকে ফাইন, ঠিক আছে, তাহলে আজকের জন্য ক্লাসটা শেষ করি। হ্যাঁ ঠিক আছে,
থ্যাংক ইউ।
থ্যাংক ইউ স্যার। আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।